Good morning. Very soon you'll have another option to provide our citizens after you've ended your patient care. Currently, our options for non-emergent patients are to transport to the emergency department or leave them at home, hoping they'll seek follow-up care on their own. We will be doing a referral program with Dispatch Health on a trial basis within a set area of Central Pierce Fire and Rescue. This program has been approved by our MPD and the State Department of Health. I do want to emphasize that Dispatch Health is a resource for our citizens after we have ended care, and our personnel shall not have citizens contacting Dispatch Health in lieu of calling 911. Many of you know Carrie Austin. Carrie is the Regional Market Director for Dispatch Health, so at this time I'd like to turn it over to her to explain the referral process. Thank you and have a great day.
Hi, I'm Carrie Austin from Dispatch Health, and I'm here to introduce the Central Pierce Fire FD Cares and Dispatch Health Treat and Referral Program. The purpose of this program is to ensure that we match treatment and care options to the needs of the patient while demonstrating optimal patient safety and quality of care, thus increasing unit reliability to include engines, ladders, and medic units. With that being said, I'd like to introduce the Dispatch Health team in the local Tacoma market, comprised of myself, the Regional Market Director, Dr. Ari Malka, who is our local medical director, and Jonathan Franz, our lead APP. Before we move into the workflow between Dispatch Health and Central Pierce Fire, I'd like to introduce Dispatch Health and briefly go over our capabilities and how patients are referred to our service. Patients can access Dispatch Health in one of two ways. They can directly access us via the web at dispatchhealth.com, our mobile app via Android or Apple, or calling us directly at 253-271-9720. The other method of referral is community-based, in which they are sent to us via their medical team, which is comprised of their PCP, their specialty providers. It can be a senior living community caregiver, a home health agency, or by accessing 911 and EMS referrals. When a patient accesses Dispatch Health, they go through a robust risk stratification process to make sure that they are appropriate for our service. With that being said, Dispatch Health is a mobile urgent care service that has the capabilities of treating 70 to 80% of what a normal ER can do. However, during that risk stratification, we're able to weed out about 20% of patients that are having time-sensitive or emergent issues and escalate them to the closest, most appropriate ED via 911 based on their chief complaint. Once a patient has gone through our risk stratification and is able to schedule a visit for the same day, typically this occurs within 60 to 90 minutes of the call, but can be pushed in upwards of 2 to 3 hours during our peak busy times. With that being said, we try to accommodate each and every patient with the same day visit. Now, once scheduled, a nurse practitioner and or a PA, along with an EMT trained tech, will arrive in the home to provide care to the patient. If at any point they deem that the patient's complaint isn't quite matching up with what it is that they're seeing upon evaluation, and before they provide any treatment, and or the patient has had a decline in status, our team has access to a board-certified ED physician at all times. They can do this via phone and or via telemedicine through our iPads. So we're able to actually do that face-to-face with the physician, with our patients, if need be. Now, the way that we're successful in treating 70 to 80% of those patients that can be seen in an ER is we travel with an incredibly robust system. And that system is comprised of a CLIA-certified lab, which allows us to do an H&H, a Chem8, an INR, a lactate. We can perform rapid streps, rapid flu, rapid mono. We're able to dip a urine. If it dips dirty, so to speak, then we can actually send it off to the lab for cultures. With that being said, we're also able to start first-line antibiotics in the home because we travel with the pharmacy to include IV and PO medications and IV fluids. We also have an EKG machine and 6 Pelican briefcases to include a GI-GU kit, an ENT kit, an ortho kit that provides the ability to splint non-angulated fractures and or sprains. We can do laceration repairs, nasal packing, sutures, cath insertions, digital blocks, and incision and draining of abscess, just to name a few. With that being said, if a patient requires any kind of radiology testing, we have the ability to write an order. If the patient is stabilized and mobile, we have the ability to treat and refer for radiology testing. But if the patient is non-mobile, bedridden, or does not have access to transportation, we actually have mobile radiology come to them. And with that being said, we can perform x-rays, ultrasounds, and echoes in the home via MobileX, our radiology partners in the market, to perform those exams, so again, keeping the patients inappropriately out of the ED. So what we want to do is make sure that as we're supporting fire and 911 and essentially Central Pierce, we want to make sure you understand when not to call us. So again, any complaint that is time sensitive or requires immediate intervention is inappropriate for dispatch health services. We want to make sure that we're here to support 911, not replace 911. So with that being said, anything that is deemed time sensitive should stick with 911 and not be referred to us. So how do you get a hold of us? Well, right now, initially, we're going to start with any CPR unit responding to station 61, 63, 65's response area. And the way we're going to do so and how we're going to request a dispatch health visit is, number one, use the patient's phone to place the call to dispatch health. This allows your phone to stay operational and you guys can receive any of your inbound calls on your rig phone. But also it gives the patient the opportunity to have the dispatch health's phone number in their phone for future reference should they need anything regarding billing or any kind of lab results. But again, we want you to utilize the patient's phone to place the call to dispatch health, and then be prepared to provide your first and last name, your callback number, your agency, and then the patient's name with chief complaint. It should be very quick and succinct, and this allows you to get off the phone and hand the phone over to the patient or POA to complete the rest of that onboarding and intake process. So again, utilizing the patient's phone, you give your first, last name, identify yourself as being with Central Pierce Fire, your callback number in case the phone call is dropped, and then again the patient's name with chief complaint, and then hand the phone to the patient or POA to complete that onboarding and risk stratification process. Now you'll notice an asterisk next to that risk stratification process, and I want to emphasize that because this is a trial, we want to ensure the safety of the patients first and foremost, and we want to promote positive outcomes. With that being said, if we get to a point 3, 6, or 9 months into this process where we've identified and had appropriate patients referred to our service consistently without any major outliers or ill-foreseen negative outcomes, we're going to be able to look back on our process within the call center and skip that risk stratification process. In other words, and what that means for you guys, if we make this a very successful trial in the next 3, 6, and 9 months, when the patient calls, we'll be able to use your assessment on scene as our risk stratification process and bypass that, which will decrease the amount of time that a patient spends on the phone during the intake process and gets you guys back in service much more quickly. So once the patient's been approved and assigned to one of our provider teams, we will provide that patient with an estimated time of arrival. Again, most often this is within 60 to 90 minutes of the time that the patient calls, but realistically can be pushed to 2 to 3 hours during peak times, which is later afternoon, early evening. Again, we do strive to make sure that we respond to the patient same day regardless. If at any point you're requesting care in the latter part of the evening and we don't have any ability to get the patient in, we will offer the patient, if they're stable, the first available appointment the following morning. Again, giving the patient the opportunity to stay in the comfort of their own home to receive care versus inappropriately self-referring to an urgent care or ER service. And I know that Tim Lukabal will go over this with you, but once the patient has been signed and given an estimated time of arrival, you will have the patient or POA sign the treat and refer release on the EMR and then be able to return to service. So at this point, we'll go over some questions that we generated earlier in some discussion regarding Dispatch Health. And first and foremost is, how long does the intake process last, and do the crews need to stay until it's complete? The intake process for initial calls, in other words, a patient is the first time they've utilized Dispatch Health service, on average takes 8 to 10 minutes. So this is 8 to 10 minutes that you're going to spend on scene while the patient answers the CSC's questions and goes through the risk stratification process. This is considerably a shorter amount of time than it is to transport a patient to the hospital and either wait for a bed and or offload in the triage area and then get back in scene or on scene. I should say in service. So it is a faster process for you, but again, it is going to take about 8 to 10 minutes for that initial intake process. And do the crews need to stay until it's complete? Yes. This is to make sure that at any point during the risk stratification, if we feel that the patient doesn't meet our services or doesn't qualify for our services, then you guys have the ability to A, transport the patient anyway, or B, discuss other options with the patient as far as care. So, hours of operation, current staffing, and cost to the patient. So currently we operate 7 days a week, 365 days a year, 8 a.m. to 10 p.m. We often get the question of, are we going to go 24/7? And the answer is no, because nothing good happens between 11 p.m. and 7 a.m. So we're going to allow EMS and 911 to hold on to that 11 p to 7a wedge of hours, if you will, and we're going to continue to service our patients 8 a.m. to 10 p.m. Now, as we grow in the community, there may be the ability to come in a little early and start at 7 a.m. and maybe even push up to that 11 p.m. But currently, our hours of operation within this market are 8 a.m. to 10 p.m., 7 days a week, 365. We currently have 3 teams operating within the community, which gives us the ability to see on average 24 to 30 patients a day. Now, as we push capacity, we'll be able to add additional teams, which will give us additional capacity and thus begin to add stations and coverage area within Central Pierce's district. And then cost to the patient. What if the patient doesn't have insurance, or if they do, what's the cost? So we have a flat fee for service, which is $275. So if at any point a patient doesn't have insurance or has a high deductible PPO in which they've not met the deductible, the most that will ever cost a patient is $275, which historically speaking, when you look to ER costs, that is significantly less than the cost of going to an ER. Now, if a patient does have insurance, and we are contracted with most commercial payers as well as Medicare and Medicaid, it is whatever the cost for their urgent care copay would be, again, once they've met whatever pre-existing deductibles they have through their plan. So for your Medicare and Medicaid patient population, it's usually a zero cost for us to come out to them. And then commercial patients usually on average pay $30 to $50 for our services. Now, who else refers to Dispatch Health? As we touched on in the beginning, we receive the majority of our referrals, A, from direct to consumer. In other words, the patient contacts us themselves. But our highest utilizers in the community and highest referral rates come from home health agencies, senior living communities, primary care physicians, nurse triage lines, and then specialty providers. So knowing that you're going to be spending 8 to 10 minutes with that onboarding process, or the patient's going to be spending 8 to 10 minutes on that onboarding process, what can you do to expedite that? In other words, how can you get back in service faster? The easiest thing to do is to encourage the patient to have their photo ID and their insurance card ready to go before calling the CSC to do the intake process. So again, if you can have the patient with a photo ID and their medical insurance information, that will help expedite the intake process and get that done more quickly so that you guys can get back in service. Now, this is an exciting program. I understand that we all want to utilize it, but what if you are outside that initial coverage area that we went over just a few minutes ago that is comprised of 61, 63, and 65? Can you refer to Dispatch Health? The reason we went with 61, 63, and 65 is that is one of the highest ED utilization areas based on heat maps that we have done through Dispatch Health. So these are patients that tend to inappropriately present to the ED most often. Now, we also don't want to outmatch or outrun the capacity that Dispatch Health currently has. So by starting with just 3 stations, we're able to grow as we add additional cars and treatment teams in the area. So by keeping it at the initial 3 stations and that catchment area within those three areas, as we start to begin to push capacity and you guys send us more and more and more referrals, we're able to add additional teams and add stations, and thus the goal would be being able to cover the entire Central Pierce coverage area by the end of the year. Now, what if Dispatch Health is at capacity for the day? We don't want to say the dirty D word, which is divert, but should we meet capacity for the day, I will do my best to make sure that the EMS division is made aware, and then they can send out a mass text or messaging system to the crews to let you guys know that we're at capacity for the day and we're unable to take any additional patients, so that you're not spending time waiting for a patient to go through the onboarding or intake process just to find out that we've been booked. So again, if we're at capacity for the day, we will do our best to make sure that the EMS division is aware of that, it's relayed to you guys, and therefore you guys know that the patients will either need to have additional, they either need to go to the ER or you guys need to make alternative arrangements for them. And then last but not least, do we treat homeless patients? Yes, we do. Most homeless patients have either Medicare, Medicaid, or a combination of both coverage. Most aren't going to want to use us if they have to pay the flat rate fee of $275, but if they do have insurance coverage, we can see homeless patients as long as there is a safe, appropriate place to do so for my team to come out. So when I send out my nurse practitioner or PA with my EMT, they need to be able to have a semi-private place in which to perform an exam, and they need to be able to do so in a place that's safe for not only the patient but for the team. So we're unable currently to go, and we've had requests for things such as Starbucks, McDonald's. We can't go to any place that serves food, if you will. But we are most certainly able to go see patients at the Tacoma Rescue Mission or Nativity House, in churches, shelters of any kind. We try to avoid tent cities, if you will, just because it's not necessarily safe for my treatment team. But we will see homeless patients. Again, if you have the ability to find us in a safe place to do so, my team is willing to go out and do that. So that's it for the questions that we discussed beforehand. In the meantime, I want you guys to take this information, this slideshow, and the additional information that will be provided to you by your EMS division. And if you have any questions, concerns, comments, or anything, please feel free to send those directly to Dan, and then he can forward those to me, and we can make sure that we address them in a timely manner and an appropriate manner. So really looking forward to partnering with Central Pierce Fire in this. And if you guys have, again, any questions, please let Dan know, and I'll do my best to get those taken care of. Thank you so much, and enjoy the rest of your day.
No problem. So just so everyone's aware, we have put a new outcome for your choices, like where you say treated and transported. It now will say treated and referred to mobile integrated healthcare. If you just choose that choice, then there also will be a new signature line. The signature line will be just CPR treat and refer signature. There will be an attached document so that you can see exactly what they're signing. Please will make sure that you get those signed on any of these that you're referring. We will force it to have a signature anytime you choose treat and refer to mobile integrated healthcare. If you have any questions, feel free to contact me or anybody in the EMS division.